Very important speech, that is the role of communication in the healthcare sector. So I invite Mr. Arun to enlighten us more on this matter.
A very warm good morning to all. It's so nice to see such eminent personalities together. Myself, Arun, I am coming from Cochin. I am the quality controller at M.O.S.C Medical College. Earlier, I was working with ISOS, and that is why I know some of you. And first of all, thank you very much, Dr. Devin, for giving me this opportunity, and QPMBA for this opportunity. Dr. Anna, that was a wonderful presentation. Thank you very much. My topic is communication in healthcare. Could someone please play the presentation? Is it showing? Yeah. Yeah, I will. Okay. Now, I think all of you will agree with me when I say that 90% of our problems in the hospitals arises from some kind of miscommunication. I think you will all agree with me. So just like Anna said, this is a very wide topic, and actually I cover this topic in 75 hours for my MHA students, this communication, healthcare communication. So I'm totally worried how I will be able to cover this topic in 15 minutes. So what I did was I have tried to focus on NABH 5th edition standards. Well, let's see what this NABH says about what should be done in terms of healthcare communication in healthcare. Some major areas has been covered by Anna, those patient safety related things. The rest I will cover. Now, if you look at the standards, let me repeat, this is about the 5th edition standards. Around 84 objective elements out of the 652 are in one way or other related to some kind of communication. And these are the major, you can, if you are interested, you can take a photo. These are the major objective elements where some kind of communication with a patient and a family. Once I forgot to tell you one thing, we will limit today's discussion to patient and family communication alone. Communication with patients and family alone. We will leave the rest communication for another this. Now, these are the major objective elements where NABH specifies there should be a communication with the patient or family. And for easily understanding, I have classified them into 4 categories, which are display related, documentation related, discussion related, and discussion advice related. Displays where a board is required, some kind of a public display is required. Documents, a medical record is to be created or used as for that communication. And discussion, oral communication with the documented evidence. Advices will also come under this thing. We will quickly move through those requirements. These are the display requirements which you need to do, which the assessors will be checking at the time of assessment. These are the minimum requirements. You have to show them display the scope of services. And priority access, you are supposed to give a priority access to sick patients when they are waiting in the OP room. If the patient is sick, you have to give them a priority consultation. So that has to be displayed. Safety signages, awareness on organ donation, patient rights, patient responsibilities, your pricing policy. You are not supposed to display your prices, but your policy should be displayed. Okay, this much will be your room rent, this will be for ICU. The minimum pricing policy needs to be displayed. Then procedure for complaints and feedbacks, your mission, vision, values, and service standards. You have to publish your ownership of the hospital, and your affiliations and accreditations need to be published properly. As for documents, treatment summary for reference out, just like discharge summary, diagnostic reports, blood donation counseling in transfusion consent, and informed consent, different types of informed consent. These are the minimum communication-based documents which you are supposed to prepare when you are going for NABH full accreditation. Now we come to the third part, is the discussions. You are supposed to discuss, you are supposed to tell your patients regarding the following points, and an evidence should be available in the patient document. You need to tell them about the changes in schedule of doctors. When a doctor will not be coming or will be late for an OP or a procedure, you have to tell them. You have to tell them, you have to include your patients and family in your discharge planning. You have to take their opinion also in discharge planning. Family counseling in ICU, and let me remind you, this must be documented. Patient counseling needs to be documented. This is a simple but powerful tool also. Otherwise, when something goes wrong, people will tell that we were not informed. If we have a clear documentation on this thing, that is why we use we use a format where there will be time, the name of the doctor discussing, name of the bystander receiving that counseling, and major points of counseling will be documented in that. When another bystander will come to you and tell you that we were not told, you can show it to them. Also, it's having a legal validity also. Now, support for relatives, pediatric patient and family education needs to be documented. Support for relatives in case of EOLC, end of life care. Counseling on usage of implants. Information regarding change in condition of patient. These are discussion related. And now, advices. The patient needs to be given advice on safe and effective use of medication, diet counseling and food drug interactions, diet and nutrition, immunizations, pain management techniques, the specific disease counseling, preventing HIIs and infection control. You need to show the proof for these counseling, these advices when the assessment comes. Now we will move into the real topic, the addressing patient communication. I would like to classify this into two categories. One is general communication and the second one is enhanced communication. General communication is whenever your doctor or nurse or your staff is talking to a patient or a family member. And enhanced communication, it covers those situations where a specialized communication is required. Like when the doctor is telling the patient that he is having a terminal illness, or when you are telling your a family member that the patient is expired, or when you are talking to an aggressive patient. These are the enhanced communication situations. Now, under general communication, you have to see that your communication is effective. We will come to that in the upcoming slides. And also, you have to define and train them on unacceptable communications. Now we will look into enhanced communication. As far as enhanced communication is concerned, we need to define the situations where an enhanced communication is required. We need to identify persons who will be giving that counseling. We need to document protocols on how the patient should be communicated, should be counseled on each of these enhanced situations, and we need to show them training proof. Now, normally, these are the identified enhanced communication, or these are the minimum enhanced communication situations the NABH mandates us to cover. Breaking bad news, counseling for complicated interventions, communicating with relatives of an expired person, talking to an aggressive person, and communication in case of adverse events. This adverse event can be anything from a disaster to a small fire or anything. It can be any adverse event. That has to be handled on a case-to-case specific basis. And others, we will see how others can be handled. Identify providers. Normally, the breaking of bad news has to be done by the doctors. Counseling for complicated interventions can be done by the doctors or trained counselors. Communicating with a relative of an expired person or aggressive person or disaster communication or adverse events can be done by trained doctors, nurses, counselors, and other persons. Security officers will come into picture when it's an aggressive person. So what we need to do is that we need to identify these persons and we need to show that we are giving them training. Now, for breaking bad news, you have spikes protocol. Most of the doctors will be aware of that, or you can get the details from the internet. Spikes protocol is used for handling breaking bad news. Counseling for complicated interventions is subjective. Depending on the case, you will have to handle that. you will have to make a protocol on that. Communicating with the relative of an expert person, again, empathy and listening will be the tools. There are explanations which you can get from internet and all. And handling an aggressive person, this is the pattern which we normally do. We identify the correct bystander, we isolate the person, and we inform them what is the situation is. From my over a decade of experience in general administration, identification of the correct bystander or correct person and isolating him from the crowd is the minimum requirement for handling an aggressive mob. Now, adverse events, again, it is subjective. Based on the case, you will have to handle that. Now we will see what are the effective communication. We call it 7 C's of communication. It's very simple. Whenever your staff is talking to a patient or a relative, make sure that they are courteous. Courteous means they properly salute them, they introduce themselves, that is mandatory, and they try to create credibility. Creating credibility is an art. Your uniform, the neatness, your tidiness of your staff, everything counts into creating the credibility. Now, second one is consideration. The staff should be trained to be considerate. They should be capable of listening properly. They should be able to identify the patient's condition or receiver's condition. Next one is the communication should be clear. The language, they are not supposed to use jargons. Use of technical terms and jargons is a major problem in communication in healthcare. And to the doctors who are present here, please understand that you are not supposed to use jargons or technical terms in the consent form. That is not acceptable. Consent is a document which should be understandable by the patient, and if your doctors are using jargons, technical jargons, or short forms or abbreviations in a consent, please tell them not to do that. Now, concise. Teach them to speak in a concise manner, to keep it simple and short, and concrete. Be sure, use fact and figures, be specific and not fussy, do not beat around the bush, and tell them what they are supposed to know. And give only correct information only. These are the 7 C's of communication. 7? No, one more is there. Communication should be complete. So these are the 7 C's of communication. So whenever you are making a protocol or a policy or a procedure on effective communication, you can base this, you can make this based on this, these 7 C's of effective communication. And the last point is unacceptable communication. This is another important thing. You have to define what is an unacceptable communication in your hospital, and you have to train your staff regarding unacceptable communication. Most of you will be aware that any communication disclosed by a patient to a doctor or a healthcare provider is a privileged communication, and a privileged communication cannot be used for any other purposes than other than for the same purpose that it has been disclosed. Patient is telling you about himself, his condition, only for availing treatment. You cannot use that for any other purpose legally. So please tell your staff to restrict themselves while communicating in front of other patients. They are not supposed to talk about one patient in the presence of family members of other patients. Use of offensive, abusive, and insulting communication is restricted. It should be restricted. See, when we write it down in a protocol, we will laugh on ourselves like, everyone knows this now. We will think like that. But when we read the patient feedbacks and complaints, you will realize that only we know that our staff doesn't. This is the actual scenario happening. So you make it very clear. You tell them that you are not supposed to talk to patients or bystanders or relatives or your customers in using such wordings. Now, there are some unacceptable non-verbal communication. Some gestures or unwanted gestures, unwanted actions, facial expressions, etc. Only a very good trainer can teach your staff. So try to train your staff on body languages also. communication violating patient rights. You will be deciding, you will be documenting, you will be displaying your patient rights. Train your staff that these are patient rights and you cannot violate them. So a training on patient rights will work out a training on unacceptable communication also. And the last one is hurting their sentiments. We Indians are slowly increasing our array of sentiments. So it's very sensitive now. So you cannot talk to them in case of race, religion, case, job, ethnicity, and the list goes on. I hope I have completed in my allotted time. Hope there are no doubts. In case of doubts, you can contact me personally. Any doubts? Okay. Thank you.